Lanoxin, or it is more commonly known by its generic name, digoxin, is a cardiac glycoside. It is considered an inotropic agent, which can come in handy for a patient with heart failure because when taken regularly, digoxin will increase the cardiac output. This drug is considered a second-line drug for heart failure. One thing to note is that taking this drug will not prolong the patient with heart failure's life, but it will help reduce the symptoms of heart failure. Digoxin is used to increase the contraction of force of the ventricles of the heart. It does this by acting as an inhibitor to the sodium-potassium ATPase enzyme. When this enzyme is inhibited, calcium begins to build up in the cardiac muscle cells because sodium-potassium ATPase is not able to remove sodium from the cell. An increase in the calcium levels leads to an increase in force of myocardial contraction. By enhancing the influences of the vagus nerve on the heart, digoxin is able to increase electrical conduction through the AV node. This results in a prolonged refractory period, or the period of time in which the AV node is responsive to stimulation. This assists in decreasing the heart's rate. Because sodium-potassium ATPase is not localized only in the heart, but is also found in the kidneys, digoxin is able to suppress renin release. This prevents renin from interacting with angiotensin. This means that angiotensin 2 is not made to its regular extent, so it cannot act on the kidneys to cause retention of sodium in water. When sodium and water are not being retained, extracellular fluid is decreased, as is vasoconstriction and blood pressure. The decrease in blood pressure through a number of actions prevents cardiac remodeling. Digoxin is used in patients who have heart failure because of its increase in myocardial contractility and resultant increase in cardiac output. When the patient who is taking digoxin's cardiac output increases, there is a decrease in sympathetic tone. This is because the increased cardiac output results in an increase in arterial pressure, which causes a decrease in heart rate. This is beneficial because a decreased heart rate allows for the heart's ventricles to fill more. Additionally, the decrease in sympathetic tone lessens the constriction of the arteries, which decreases the afterload, allowing the ventricle to empty better. Like the arteries, the venous system also relaxes, which reduces peripheral edema. Because there is an increase in cardiac output, digoxin causes increased urinary output, secondary to increased blood flow to the kidneys. When more water is being diuresed, less water is circulating in the vascular system. When there is less water in the vascular system, there is a decrease in pulmonary congestion and edema as well. The increase in arterial pressure also causes renin, aldosterone, and angiotensin 2 to decline. This results in a vasodilation, which further reduces afterload and also reduces the sodium and water retention, further reducing blood volume. If digoxin is given at doses lower than what is needed to increase the myocardial contractility, it can act on the kidney, suppressing the release of renin by promoting absorption of the sodium in the renal tubules. Also, at these lower doses, digoxin can cause a decrease in the sympathetic outflow from the CNS by means of the vagus nerve stimulation. This, through a cascade of events, results in an increase in sensitivity of the cardiac baroreceptors. Finally, and importantly, digoxin has electrical effects on the heart. This is what makes it useful in treating dysrhythmias. Digoxin has the ability to change the electrical activity within the SA node, AV node, and Purkinje fibers, as well as the musculature of the ventricles. Digoxin increases the rate that the vagal nerve fibers fire, as well as increases the effect of acetylcholine on the sinoatrial node. In patients with atrial fibrillation and atrial flutter, digoxin can be beneficial because it slows down the ventricular rate. This allows for more complete ventricle filling and increases cardiac output. For patients with supraventricular tachycardia, digoxin is used to increase the cardiac vagal tone and decrease sympathetic tones to suppress this dysrhythmia. Digoxin can be administered orally and IV. It is important to note that administering this medication intramuscularly will result in both tissue damage and pain. Thus, the IM route should be strongly avoided. Digoxin is excreted by the kidneys and has a 1.5-day half-life. When taken orally, effects are seen after 30 minutes with an expected peak within 4 to 6 hours. Digoxin can be administered by mouth as tablets available in 2 doses, either 1/8 milligram or 1/4 milligram, and also as an elixir for use in pediatric patients. When used intravenously, digoxin comes in 2 formulations, 1/10 of a milligram per milliliter and 1/4 of a milligram per milliliter. Previously, due to the fact that digoxin levels take 6 days to plateau, patients would be given a loading dose. This process was termed digitalization. This is no longer considered appropriate for patients in heart failure. Most commonly, there are gastrointestinal and central nervous system side effects. Of the GI side effects, nausea, vomiting, and anorexia are the most common. These side effects are triggered by the stimulation of an area of the medulla known as the chemoreceptor trigger zone. Of the central nervous system side effects, the most common one is fatigue, but patients also experience visual disturbances such as blurry vision, objects appearing darker than they are, halos around things, and a yellow-green tinge to everything.
As previously discussed, digoxin alters the distribution of ions across the cardiac cell membrane. It alters the electrical responsiveness of the cells. This is useful in treating dysrhythmias like AFib, but it can also act in several ways to cause cardiac dysrhythmias. The most common cardiac dysrhythmia that can be caused by digoxin is AV heart block, and the most dangerous are ventricular tachycardia and VFib. Dysrhythmias are more common in those with an elevated serum level of digoxin, those with heart disease, and in the presence of hypokalemia. Digoxin also has multiple drug interactions. Loop and thiazide diuretics promote the loss of potassium and can increase the risk of digoxin-induced dysrhythmias. ACE inhibitors and ARBs cause increased potassium levels and can thereby decrease digoxin's therapeutic effect. Verapamil can cause increased serum levels of digoxin, and it can also suppress myocardial contractility and counteract digoxin's benefits. If a patient is taking both digoxin and verapamil, the digoxin dose may need to be reduced. Quinidine can promote digoxin toxicity by reducing its renal excretion and causing increased plasma levels of digoxin. Sympathomimetics like dopamine and dobutamine can increase heart rate and cardiac myocontractility, which can increase the risk of dysrhythmias. Nursing implications for digoxin. There are several labs that we need to monitor in these patients. The first is the digoxin serum level, which has a narrow therapeutic range of 0.5 to 0.8 nanograms per milliliter. This should be monitored until therapeutic range is reached and annually after therapy is established. Hyperkalemia can impair digoxin's therapeutic response, and hypokalemia can cause digoxin toxicity and dysrhythmias, so we need to monitor our patients' potassium levels as well. We need to check BUN and creatinine in these patients because kidney impairment can cause toxic accumulation of digoxin. In patients with renal impairment, we should anticipate a reduced dose. Patients must have continuous cardiac monitoring via telemetry during administration and for 1 to 2 hours after digoxin is given. We need to take their vital signs, including BP, heart rate, and an EKG before this med is administered. And we should hold this med if the heart rate is less than 60 beats per minute, or if there are changes in heart rhythm, and we should contact the provider. In cases of digoxin toxicity, we should anticipate the use of the reversal agent digoxin immune fab or digibind, and the patient may need to be transferred to the ICU. In terms of patient education, there are a few things that the patient should be taught to report to their provider immediately. They should take their own pulse and report changes in rate or rhythm. They should also report symptoms of digoxin toxicity like nausea, vomiting, fatigue, blurred or yellow tinge vision. They should report signs of hypokalemia like muscle weakness or muscle cramps. Other points of education are that the patient should take digoxin exactly as it's prescribed. If a dose is missed, they should not double dose the next day. It is okay to take digoxin with food, but they shouldn't take it with food containing bran, like oatmeal or whole wheat bread. Because of multiple drug-drug interactions, these patients should make sure that all providers know that they are taking digoxin before they start any new meds. Digoxin is pregnancy category C. It poses a greater risk than categories A and B drugs. Animal studies show risk of fetal harm, but no controlled studies have been done in pregnant women. Digoxin may be prescribed if the provider and the patient determine that the benefits of taking this drug outweigh the risks. And these are our references.